Thanks very much, and I appreciate the invitation to talk about TB therapeutic strategies. So in this talk, I'm going to cover a little bit about standard treatment and its limitations, and then talk about new approaches to shortening treatment, including better sterilizing drugs, novel drugs and repurposed drugs, talk a bit about adjunctive host-directed therapy, and focus a fair bit on innovative treatment strategies using the tools that we have already to achieve better outcomes for the majority of people with TB. And then at the end, say a few words on biomarkers. So the standard TB treatment lasts for 6 months with initial 2-month induction phase with 4 drugs, and then a 4-month continuation phase with 2 drugs. And the problems as perceived with this regimen is that 6 months duration is viewed as too long, that adherence is hard to maintain for patients for this duration of treatment, and erratic adherence leads to resistance, which is often subsequently transmitted. And furthermore, the treatment is not that well tolerated. So to improve upon the standard treatment, what we really need to try and do is shorten it. So for drug susceptible disease, shortening from 6 months to something around 2 months. 10 days really a bit out of reach at the moment, but most people in the field are thinking that 2 months is probably an achievable duration within the foreseeable future. Why do we currently treat for 6 months, and why is it so hard to give shorter periods of treatment for TB? Well, the answer is that when TB bacteria are exposed to drugs, they go into a dormant state, and it's very hard to kill them. They become phenotypically resistant to most of the TB drugs. They do die slowly, but if you stop the treatment before all of them have died, then one of them can reactivate, or a number of them can reactivate and set off a relapse of infection. So the problem is how to get to these dormant bacilli. And essentially the 3 approaches to shorten treatment for TB, which I'm going to talk about. The first one, using new drug regimens with drugs that have improved activity against these dormant or persistent bacteria, so-called improved sterilizing activity. The second approach is to try and use the immune response to improve the immune response to clear these persistent bacteria that the conventional antibacterials can't reach. And then lastly, to try and come up with new treatment strategies to work with these constraints to achieve better outcomes. So I'll start with the first of these, trying to improve the sterilizing activity of the regimen. So this is the current TB drug pipeline, going from early stage preclinical through to phase 3 on the right. And you can see in phase 3, there are 3 drugs listed there, bedaquiline, delamanid, pretomanid. So bedaquiline has been effectively licensed now for nearly 10 years, delamanid for over 5 years, and pretomanid just recently. Delamanid and pretomanid are in the same drug class. Bedaquiline is separate. So a relatively limited number of drugs in phase 3, and most of them licensed already. Actually, it's a bit more interesting to look at phase 2. We've got a number of drugs here, actually 3 novel chemical classes of drugs. So TBA 7371 and the Otsuka drug, GSK 656, and then Telasabec, each of them in a new drug class, the TBA and OPC in the same drug class. So this is quite promising because these may have better activity in combination with drugs from different classes. So this is quite exciting. This is the results of the next TB trial, which shows the potential and the revolution really that these new drugs can make. So this trial was treating multi-drug resistant TB and patients with XDR TB. So MDR TB up until really a couple of years ago, the standard treatment combination was given for 18 to 24 months, involved injectable drugs, which was highly unpleasant. And the outcomes were 80% cure rate at best. And for XDR-TB, essentially until recently, it was essentially incurable. So very hard conditions to treat. And yet this new 6-month fully oral regimen with bedaquiline, pretomanid, and linezolid, just 3 drugs, 6 months orally, sterilizes the sputum by 12 weeks in close to 100% of people with MDR-TB or XDR-TB. And that translates into close to 90% cure rate for both conditions. So relapse-free cure 6 months after stopping therapy, 90%. So really very impressive responses, some trade-off with toxicity, but this is really revolutionary for people with hard to treat TB and shows the potential of these drugs. But it's not only these new drugs and the new drugs in phase 2 that are coming through, but also we've had a number of successes with repurposing or optimizing existing drugs. So linezolid and clofazimine repurposed from other infections, now part of the WHO recommendations for MDR-TB treatment. And then beta-lactams and high-dose rifampicin repurposed or dose optimized, which I'll talk a little bit about now. So firstly, repurposed beta-lactams. We've known for a long time that beta-lactams have some activity against TB, but it's limited by the beta-lactamase inhibitor produced by TB. But carbapenems, given with clavulanic acid in augmentin, appear to have very good activity against TB, and this was first shown with meropenem. This study has come out this year, looking at a number of different options with carbapenem. So in the top left panel, you can see this is just a 14-day initial sputum sterilization response. So this is what you get with standard 4-drug therapy. In the bottom left panel, we've got meropenem given intravenously 3 times a day, 2 grams 3 times a day. Again, a very clear treatment response. In the same trial, there was a lot of optimism that ertapenem, which is conventionally given just once a day, would be equally good, but essentially it did nothing. Now, the problem with meropenem given 3 times a day, in fact, anything given 3 times a day, for a program setting, that's very challenging. So in this trial, they also tested meropenem in a much higher dose, in fact, the same total dose given once a day, and found a very impressive response. So essentially, this looks like once a day meropenem intravenously is something that in very hard to treat patients could also become part of the armamentarium, providing this pans out in terms of cure in longer term studies. I mentioned rifampicin, so there's a realization now that we've been for the longest time probably underdosing rifampicin at 10 milligrams per kilogram, and a number of studies have now looked at using high doses of rifampicin up to 35 milligrams per kilogram, in some cases even higher, are showing better responses with sputum clearance. And there are now several large-scale randomized controlled trials that are looking at high-dose rifampicin with longer-term outcomes. So we'll get the results of those within the next couple of years, probably. So that's it for the more conventional approach of finding or repurposing antibacterial drugs. But let me now say a few words about improving the immune response to clear these persistent bacteria. Now, the immune response is pretty good in TB. It's not perfect, but it gets you a long way. And if we can just tweak what is already a relatively good immune response to clear these remaining bacteria, that could be a very successful approach. Now, the oncologists have been thinking about this for the last decade or so, and essentially it's revolutionized the field of oncology. And there's a lot of opportunity to do that in TB as well. The interaction between mycobacterium and the host cell is very complicated. The bacteria manipulates a number of the host immune responses to dampen them down or make them ineffective. And if we could intervene with drugs to reverse that disruption of the host immune response, then we could potentially improve the outcomes quite considerably. And there are a number of ongoing or recently completed trials which have looked at host-directed therapy interventions. The top one, pascalizumab, is something we've tried in Asia. It's an anti-IL-4 monoclonal antibody. The trial is completed. The initial results look quite promising. The next 4 have been tested in a trial in South Africa. Everolimus and CC1050, an mTOR inhibitor and an anti-inflammatory compound, respectively, appear to show some benefit, at least on lung function, if not on the antibacterial responses. And the other drugs also in trials, a lot of interest in statins as well. So watch this space. There's a lot of activity probably going to increase. And again, in the relatively short horizon, perhaps within 2 or 3 years, we may actually find something that can improve outcomes and can be part of conventional TB treatment. So lastly, thinking about things more creatively, the existing tools and how can we use them to improve outcomes. So to just understand a bit more about this, let's look back at some of the old data. These are data from very early trials done by the British MRC, actually in Hong Kong, where before they settled on a 6-month standard regimen, they actually looked at standard drugs used for 2, 3, or 4 months. And if we just look at the 2 and 3 month regimens, the standard drugs at that time, including streptomycin, the relapse rates were higher, but they weren't so high. So 15% bacteriologically confirmed, 9% confirmed with 3 months therapy. So, and many of those at this time would probably have been reinfections, which we didn't have the technology to confirm at that time. So the message is that you can cure the vast majority of patients, at least with low burden TB, with very short regimens. And so effectively what we're doing with the standard treatment of 6 months is we're over-treating the majority of patients just to prevent relapses in the minority. So we could think about changing this paradigm. Could we trade an ultra-short treatment for a moderately higher relapse rate if that wasn't too big? So we can think about a strategic treatment approach. So treating, stop treatment early, follow people carefully, and then retreating them, the minority who relapse. And the increase in relapse rate may be mitigated by better adherence, better motivation of patients with a short regimen, and better supervision that you can do in a short period of time in programs. And also the consequences of this, of the relapses may be mitigated because in programs you can shift resources towards following people and treating these relapses and detecting them early in the small number of patients who relapse, rather than trying to force people who essentially have already been cured to take unnecessary long treatment. And this strategy could be attractive to patients as well as programs in terms of convenience and quality of life for patients as well as costs. And there is a trial that's actually testing this approach. It's called the Truncate TB trial, and it's comparing a 6-month standard regimen with a 2-month regimen, and for people who relapse, they would get retreated with 6 months of standard treatment and then followed. Everybody's followed until 2 years, and we assess whether the cure rates are essentially identical in the 2 arms. If this strategy is just as good in terms of long-term cure, then we can look at the pros and cons of this strategy. Is it better for resources in programs? Is it more acceptable to patients? Look at all of the pros and cons to weigh up whether this is a better approach to the treatment of TB. There are 2 essential things for this to work. One is that the relapses all happen early, and certainly from the short course trials, this is Rifaquin trial where people in the orange line here stopped treatment at 4 months as opposed to those in the green and blue who continued to complete 6 months. You can see the relapses happen pretty much straight away after stopping treatment, and most of them are finished by month 10 or apparent by month 10, 6 months after stopping treatment. So in the strategy, if relapses happen, they should happen early. And also we can be confident from past literature that of short course regimens that when people relapse, if they've taken the medicine reliably, they should relapse with drug susceptible disease, which is then amenable to straightforward retreatment. So which 2-month regimen is this trial testing? The answer is it has to test multiple, because at this point in time, we can't pick a single 2-month combination, which would be optimal. So it's testing actually 4 experimental 2-month regimens. The first 2 have got high dose rifampicin, as I mentioned earlier. with the standard drugs, and then the first one with linezolid added, the second one with clofazimine added. The group D have got rifampic instead of rifampicin, which people are thinking is probably more active, with linezolid and levofloxacin added. And then the last one is using bedaquiline in place of rifampicin with the standard drugs and then linezolid. So different combinations using established drugs to try and get a better clearance rate, better sterilization rate with that 2 months of therapy. The trial is fully enrolled as of March this year. It's mainly been done in Asia because the strategy is very suitable for Asian patients. The follow-up we completed at the end of next year, and then we'll have results available in March 2022. And this could really change the way that we approach thinking about TB treatment. So in the last few minutes, I'll talk about something else where there's a lot of excitement in the field, and that's the use of biomarkers to try and identify people who could benefit from shorter treatment or knowing when we can stop treatment. And it's important here to just bear in mind the difference between individualized therapy and resource-rich settings. So using biomarkers there, you've got a lot more latitude in terms of what can be done strategically. But we have to remember that most people with TB treatment are receiving treatment in the public health approach. So it's simple, standardized approaches, and it has to be something that's possible in the field. So we actually have already a number of likely simple clinical biomarkers which we can use to identify people who could be treated with a shorter treatment regimen. This is data from the 3 large quinolone trials, looking at groups of people where non-inferiority was demonstrated. In each of the trials, they failed to show non-inferiority of the 4-month quinolone regimen. But when you look at subgroups, so here people who at baseline are smear negative or smear 1+, or have no cavities on the chest X-ray, or female patients, or combinations of those factors. All of those subgroups, you can see that the 4-month regimen with a quinolone is non-inferior to the standard 6-month regimen. So already we've got some factors which may predict people who can benefit from a shorter treatment regimen. There's interest in using PET-CT as a biomarker, looking at the PET-CT response to select people who could stop treatment at 4 months. And there's a trial testing that called the PREDICT-TB trial, where they're randomizing people at 4 months based on the PET-CT response to stop treatment or to continue for a 6-month regimen. Obviously, PET-CT is not something that can be implemented on a large scale in the public health approach. It's more a proof of concept that you can have a biomarker where you can tailor your duration of treatment. But the last one, which I think is really promising, is the use of blood transcriptome signatures. So this is using gene expression, and if you can get the signature small enough, down to a small enough number of genes, this could be done almost at the bedside. It can just be a point of care test, so a lateral flow test, for example, where you could look at a signature and identify people who still need to continue on treatment. So this is actually just the conventional approach, which is using a transcriptome signature. There are 4 of them shown here to separate people without TB from people with TB. So a diagnostic approach where it looks promising but hasn't really met the necessary thresholds just yet. But this just shows you with one of the signatures, perhaps one of the more promising ones in a recently published paper. First of all, that the magnitude of the signature is called RISC6. It's got 6 genes, tracks treatment response. So that's really the first thing you'd want to see with a biomarker, that it actually changes in a way that's predictable during the course of treatment. It's a good sign. And they also showed that it tracked the response of the disease visualized on a PET-CT. So it appears to meet the sort of preliminary signs that it might be useful as a biomarker. It's responding to treatment. And also, it can predict the baseline values of this risk signature, can predict the outcome of treatment between failure and cure. It's by no means perfect, but it certainly would add value in trying to potentially separate out patients who would potentially benefit from a short course of treatment, although this absolutely has to be prospectively tested in randomized controlled strategy trials. So just putting this together in summary then, we're essentially trying both for drug susceptible disease as well as drug resistant disease, trying to shorten treatment and make it more acceptable for patients. And good progress has been made with new drugs and is being made with repurposed antibiotics to sterilize bacteria, with bedaquiline, with pretomanid, with repurposed beta-lactams and high-dose rifampicin, amongst others. There's a lot of interest and an emerging number of trials with host-directed therapy, and those that have completed have shown promising data. As I've discussed, we can think about more creative short course strategies for treatment, and a 2-month treatment followed by close monitoring and retreatment of the minority relapse is being tested in the TRUNCATE-TB trial, which is ongoing and will report in the nearish future. And then the use of biomarkers, promising biomarkers to identify people who could benefit from shorter treatment, to kind of refine these strategies. And this needs to be simple for deployment in the public health approach. And particularly transcriptome signatures look promising in this regard. But in resource-rich settings, potentially one could already deploy a number of these things to think about tailoring treatment for individual patients with TB. So that's it. I hope that's been of interest and has made you think about some of the options available. Thanks very much.